Hello and welcome to today's session. My name is Hazel and I'm the course advisor for our part-time online programme in Transformative Oncology. Today I am joined by Bilal, who is our unit lead for Unit 4, the branches of oncology, and I'm going to hand over to him to introduce this unit to you in a bit more detail. Over to you, Bilal.
Thank you, Hazel. Welcome to an overview of Unit 4 of the Transformative Oncology course and programme. My name is Bilal Alkhaffaf. I am a unit lead, particularly for this one, which looks at the branches of oncology. I'm also the Deputy Director of the programme. I work closely with the rest of the unit leads and the course director, Susan Johnston. My background is one of surgical oncology. I'm a surgeon by trade. I manage esophageal and gastric cancer, and I work quite closely within a multidisciplinary team of other clinicians, allied health professionals, scientists, researchers, and that is probably the biggest takeaway message from this unit is that oncology nowadays is delivered using a multidisciplinary approach. It is not about people working in silos, and this is what we want to reflect in our unit. We want to demonstrate that the branches of oncology, whilst they are specialties within their own right, they cannot survive and they cannot function properly without close relationships with other branches of oncology. And that's not just talking about doctors, but it's talking about how nurses function with other allied health professionals. We're also going to be talking a little bit about the practical take-home lessons that you can implement in your day-to-day working lives, in your clinical practice, and in your research as well. I am supported by a wide team of healthcare professionals who will be developing and delivering the unit as a whole. Martin Stott is taking the lead from a surgical perspective. He is a surgical oncologist in hepatobiliary disease and is currently undertaking his PhD on the subject. Alexandra Lewis is a senior fellow in medical oncology at the Christie Hospital. Marianne Asnar is a radiation oncologist, as well as Ganesh Radhakrishnan, who is a radiation or a clinical oncologist as well. So the overview of this short presentation will include a little bit about what the unit's going to cover. We want to go through the aims of the unit. We want to talk about the particular skills that you're going to learn, and practical skills that you're going to be able to implement in your day-to-day practice. We need to talk a little bit about what makes this unit unique, not just within the program, but also when we compare it to perhaps other similar types of learning opportunities elsewhere and outside of the program. We're going to be talking about how the unit is not only unique in general, but how it's unique and can be useful for yourself. And we'll be talking about that when we talk about the topics that you're going to be learning as well. The branches of oncology, as I briefly mentioned, include surgical oncology, medical oncology, and clinical and radiation oncology. They are broad terms that encompass a whole host of different subspecialties, and these are some of the topics or some of the issues that we're going to be talking about today. So where does this unit fit? There are 8 units in the course program. We are the 4th unit, and as we've just briefly mentioned, we're going to be talking about medical, clinical, and surgical oncology, and importantly, how they complement one another in order to provide the best possible outcomes for patients. At the end of the day, what we do in clinical practice and in research is for the benefit of patients, and we need to be able to understand the optimal way of working with one another, bringing our expertise and specialisms for the benefit of patients. And that's probably the underpinning principle, not only of this unit, but of course of the programme itself. So I'm going to break down the unit aims according to the 3 branches of oncology, and then we're going to look at how these 3 units are going to tie in with one another. Some of the content that we're going to be presenting and some of the content that you will be participating in and some of the assessments that you're going to be undertaking will tie in the things that you'll be learning from surgical oncology, medical oncology, and clinical oncology. And we'll talk about that in greater detail shortly. There are 3 main aims from the surgical oncology section of this unit. Firstly, you're going to evaluate surgical interventions, and we're going to be looking at cancer-specific case studies in order to illustrate the different surgical interventions available. Because not every different cancer is managed in the same way. Not every type of surgery is performed in the same way. Different surgeries have different risk profiles and different downsides and benefits, and we're going to be covering all of that in this particular topic. What's important to understand is when we talk about surgical interventions, it's not just about the operating itself, but it also encompasses the entire pathway up until the point of surgery and long beyond surgery has been undertaken. So this part of the unit will cover the patient pathway from diagnosis up until the treatment. That includes how patients are diagnosed. That will include a little bit about how we prepare patients for surgical interventions. And we'll be talking about the topic of prehabilitation, how we can maximize patients' physical and mental preparedness for surgery, because sometimes the surgical treatments that we offer patients can be of such a large magnitude that the long-term effects, long-term toxicities and long-term negative side effects can be devastating. And we want to try and minimize any long-term side effects from surgery. And so it's really important that when we talk about surgical interventions and treatments, that we're not just talking about what happens in the operating theatre, but we understand that preparedness is key to providing a really good and positive outcome for patients in the longer term. So we will be talking about how to prepare patients for surgery. In the pathway leading up to surgery, another important topic is how we make the decision as to who should have surgery and who should have other treatments. There are lots of cancers whereby there may be more than one treatment option. There may be cancers which could be treated surgically or could be treated with radiation therapy, or could be treated with, importantly, a combination of chemotherapy, surgery, and radiotherapy as well. So understanding how we decide which patients should be undergoing which treatment will be an important part of the surgical decision making as well. Non-curative interventions are also an important consideration here. So surgery is not just about curing patients. So there may be surgical treatments that look to reduce the burden of cancer on the patient. As an example, some gynecological surgeries for cancer aim to reduce the bulk of the cancer to prolong patients' life. And whilst that might not be with the intention of curing patients, that is also a vitally important tool in our surgical toolkit that we'll be talking about in greater detail in this unit. The second aim within the surgical oncology subsection will be looking at the innovations, the cutting edge technology that is available in the field of surgical oncology. We've talked briefly about prehabilitation and some of the new approaches to preparing patients to surgery, But we'll also be looking at some of the technologies available, including robotic surgery, which, whilst it has been around for 10, 15, 20 years, really hasn't taken off until very, very recently. We also are going to be covering the impact of artificial intelligence and where this may lead surgical treatment in the future. And we have, as an example, a combination of perhaps robotic surgery with artificial intelligence, such that we can overlay certain images on the screen. The artificial intelligence program is able to guide surgeons how to perform their surgery in order to remove the cancer completely. And this is something which is groundbreaking technology, which will be available in the future as well. We also want to talk about some of the innovations that have come about in recent years, which can benefit patients in their recovery periods. For example, enhanced recovery after surgery is an important consideration, and is a specialty within its own right. We have international and national societies which focus purely on how to enhance patients' recovery after their operations, and that's another topic which we'll be talking about during our surgical unit. One of the principles of innovation and maintaining standards within surgery is the integration of research within the surgical field. And that's, of course, not just specific to the surgical field, but it's also important in the field of medical oncology and radiation oncology. But we're going to try and look at how we should best undertake clinical trials in surgery, particularly because over the last 20, 30 years, what we have demonstrated in the medical field is surgical oncology trials can be particularly challenging to run. And this has traditionally been a weakness within the field of surgery. However, what we have seen over the last 5 to 10 years is a focus on improving the methodology of how surgical trials are undertaken and improving the quality of the way in which trials are run within the field of surgery. And as a consequence, we will also hope that the quality of the outputs from surgical trials improve, so that we can see some of the same improvements and improved outcomes for patients in medical and radiation oncology that we can hopefully see in surgical oncology trials. And we'll be learning a little bit about the principles which underpin clinical trials in surgical oncology. Moving on to the medical oncology unit aims, we're going to be talking about the general approach to non-surgical management of both curative and palliative pathways. We're going to be talking about how we tie in non-surgical chemotherapy, immunotherapy treatments into surgical pathways. We're going to be talking about how medical oncology is a specialty in and of itself, and how it can be used as a standalone approach to cancer in not just the palliative but also the curative setting. And when we talked right at the beginning of this presentation, what was an important principle was how all of these different specialties merge together and are quite often used in pathways for patients with complex cancers to improve outcomes for patients. One of the important take-home messages that we want people to gain from this topic is that there needs to be consideration about local resources that are available. Not everyone will necessarily have access to the surgical treatments or the medical oncology treatments and chemotherapy and immunotherapy or radiation oncology, in fact, that may be available in some parts of the world. And it is therefore important for us to present alternatives and principles of management that can also be used in lower resource settings and we're going to be discussing about the principles of who has access to which types of treatment and why that might be. We'll also be talking about the general principles of systemic therapy, particularly when we talk about toxicity versus benefits to patients, and some of the discussions and the considerations that we have when talking to patients, and how we talk to patients about these toxicities and some of the downsides to medical oncology. There's lots of different new approaches to biological therapies for in the field of medical oncology. This is probably one of the most exciting developing cutting-edge fields currently in the area of cancer treatment, and we want to describe where we think some of the future treatments may lie for patients in the future, but also the impacts of some of these new innovations and what these may be on healthcare settings and healthcare providers and services and systems, not just in developing countries, but also in low to middle income countries and high income countries as well. The final third, or the final section of the branches of oncology, will look more closely at clinical and radiation oncology, in the same way that we'll be talking about the principles of surgical and medical oncology. We'll be talking about the underpinning principles of radiation therapy. We're going to be understanding why some patients can have radiotherapy and why some patients should not be having radiotherapy. What's the decision-making process when it comes to choosing radiation therapy for some patients over others? What situations may radiotherapy be beneficial over other treatments for patients? And we'll be focusing in general terms on the benefits and the downsides and the toxicities, not just in the short term, but also in the long term. And all of these things need to be brought together in order to improve decision-making for patients and also by patients. Because what we see on a day-to-day clinical practice is that patients are becoming more and more involved in their own decision-making. Patients are more understanding and undertaking far more research and have access to more research and information than ever before. And so it's important for us to understand the principles on which these decisions need to be made. And these will be brought to the fore in this topic and in this unit as part of the program. Radiotherapy, as we've talked about, has certain toxicities as well as the benefits, and we need to again balance, the benefits and the risks of radiotherapy versus systemic therapies, in addition to the surgical treatments that we've talked about before. Informed consent is the third area that we'll be covering within this subunit, and we'll be talking about not just the principles of consent for radiation therapy, but we'll also be bringing in some of the principles of consent involved in medical oncology and surgical oncology as well, because the principles are very, very similar. I think one of the areas that we can certainly highlight, and we will be highlighting, is how we can use these principles in our day-to-day clinical practice. Whether we are clinical professionals or allied health professionals, or we work in non-clinical settings, it is important to consider what is consent and what is informed consent, because one of the principal pieces of, or one of the principles of informed consent is that it is a process. It is not what has traditionally been thought of as, right, well, we're going to sit down and we're going to talk about this on one occasion, you're going to sign a piece of paper, and then that's it, you've got informed consent. But informed consent is about providing information to patients over a period of time, quite often over a course of a number of different appointments or interactions, and it can be given, or the information that's given to patients can be given through lots of different sources, through written, through verbal interactions, and by different people as well. So it's not just clinicians or doctors and nurses, but it can also be by allied health professionals, and that all formulates an informed part of consent on the patient's behalf. So we'll be talking about that. We'll be talking about also what happens when informed consent doesn't happen, and some of the implications from a medical legal perspective as well. I want to just quickly cover the elements from a marking and assessment perspective. Each element, the surgical oncology, medical oncology, and clinical oncology, it forms 5 credit elements of the 15 credits of this unit. They will be delivered over a period of 8 weeks. So you'll have 2 weeks for each branch of oncology. And as I've said to you before, we won't just be talking about each one in a different silo, but we'll be cross-fertilizing much of what we present in terms of the assessments and in terms of the presentations and the podcasts and the different material and the publications and the articles that will be available for the unit will be a cross-pollination of all 3 together. But we will generally be covering each one over a 2-week period, and then we'll have 2 weeks at the end allocated for assessments. The assessments are going to be made up of 3 main areas. There's going to be a multiple choice question section, so that you'll have an opportunity to undertake some multiple choice questions throughout the course or throughout the unit. Every couple of weeks, so at the end of the surgical oncology, clinical oncology, and medical oncology, you'll be given some multiple choice questions just to get you in the mood for the MCQs at the end of the unit. So there'll be approximately anywhere between 20 and 30 questions for you to answer on what you've learnt. There will be a reflective element, so we'll be asking you to go onto discussion boards, and again this will be on a regular basis so that you're not having to do lots of assessments in one go. And then finally there's going to be a comprehension or an assignment that we're going to ask you, which will bring together all the principles that we've covered in today's talk and allow you to use perhaps a personal experience in clinical practice or something which you have learnt throughout the unit, which will bring together the principles that we've talked about of the multidisciplinary approach to cancer treatment, which incorporates surgery, medical oncology, and clinical radiation oncology as well. So that is an overview of Unit 4, which I hope gives you a comprehensive understanding of some of the things that we'll be talking about, some of the things that we'll be covering. And thank you very much, and back over to Hazel.
That's great. Thanks, Bilal. Thanks very much for delivering that and for introducing us to the unit in detail and covering the different areas. So if this talk today has piqued your interest and you'd like to speak to me about the course in more detail, or you have any questions following today's session, then you can get in contact with me by emailing studyonline@manchester.ac.uk, and you can also see the web address for the course website and my phone number there on screen as well if you'd prefer to get in contact that way. But thank you very much for delivering today's session, Bilal, and I hope to hear from some of the people watching back and listening very soon.